Of medical ultrasound imaging. Introductory lecture for UGRA and POCUS curriculum in anesthesia residency. What is ultrasound? Ultrasound is a mechanical pressure wave, vibrations. It consists of series of compression and expansion through a medium. Ultrasound measured in hertz, cycles per second. We know that frequency of audible sounds range from 20 to 20,000 hertz. Ultrasound, by definition, is above this frequency, so frequency above 20,000 hertz. Diagnostic ultrasound uses much higher frequency, 1 to 20 megahertz, million cycles per second. How this works? It's pretty complicated, but if we really simplify, we can imagine it like this. So transducer that has a piezo crystals is a source of ultrasound, and same transducer receive echoes back. So electrically pulse, those crystals change shape and vibrate, producing sound propagating through the tissue. Then echoes that reflected back get to transducer, and in return mechanical energy now transformed back to electrical energy. Then with complicated software, computer plot those returning echo and create picture based on time and intensity of those echoes. So there are many modes of ultrasound. Most commonly, we will be using 2D image or two-dimensional mode that give us this two-dimensional picture. It's designed for soft tissue organ evaluation, such as size, shape, symmetry, echogenicity, anatomical relationship, and vascularity. Another useful mode is M mode. M here stands for motion. So if you look right here, we see example of M mode for echocardiography. This is parasternal view, and we look through the ultrasound through this line plotted in time. So this is septum, this is wall of left ventricle, and this line represents movement of anterior mitral leaflets. And here we see this movement in time, and we can measure this early point septal separation. So very handy, useful mode. So now let's talk about Doppler effect before we go to next mode of ultrasound. So we're all familiar with the fact that if we standing somewhere right here and witnessing car or train, let's say here's ambulance with a siren coming toward us and then passing by and going away from us, we all know that pitch of a siren will be changing. At the beginning, when car will be coming to us, pitch will be higher, and then eventually when car going away from us, pitch will be lower. And this phenomena is called Doppler effect. And what is Doppler effect? It's a shift in perceived frequency due to relative motion of the emitter or receiver. And as I said before, it will be shifted to higher frequency when sound is reflected from objects that moving toward us, and it will be shifted to low frequency when it's reflected from objects that moving away from us. By measuring Doppler shift, we can estimate both velocity and direction of moving object. And this Doppler shift could be presented in ultrasound machine either through the spectrum or color scheme. So one more important point here is that in order to appreciate this Doppler effect, ultrasound wave should be well aligned with moving object. Doppler effect is minimal when angle of incidence is close to perpendicular. So right here, if you're standing here and car is moving this way, Doppler effect is, Doppler shift is minimal. So now when we review Doppler effect, let's talk about a couple modes that use Doppler effect. So one mode is called spectral Doppler. And again, it's used to assess velocity of flow and also direction. It's plotted as a spectrum. So when this line goes up above baseline, it goes toward the transducer, and when it's below, it's go away from transducer. And this is subtype of spectral Doppler, pulse wave Doppler, PW. There's another one, continuous wave Doppler, that will be similar but will be field envelope. And spectral Doppler, PW or CW, allows quantitative information, assessment of quantitative information. Another less complicated mode that also relies on Doppler effect is a color Doppler. Again, allow us to see direction, to recognize direction of the flow, and kind of like eyeball the velocity. We use mean velocity data here. So let's talk about color Doppler a little bit. So we use this mnemonic, it's called BART, and BART stands for blue away, red toward, and it means that if we see red color on a screen, it means that moving object right here is blood, erythrocytes, they're moving towards the transducer. And here, if the blood flow is away from transducer, it will represent it as a blue color scheme. And you can use this mnemonic, or you may remember our rainbow and know that, red side is a lower frequency, and your blue side is a little bit a higher frequency waves. And remember, when this ambulance is going away from us, right? The shift would be toward the low frequency, so away blue. And when it will be toward us, it will be shift to more higher frequency, so it will be red. One more time, BART, blue away, red towards. Another mode that uses Doppler effect is the power Doppler. It's a little bit complicated, but to simplify, just practically, it's very appropriate for situation with a very low flow, and it's less dependent on alignments of sound with a moving object with a blood flow. So for example, here we would try to assess this particular structure. It's black pearl, right? And it could be blood vessel, but also could be nerve. So if we put ultrasound probe, here it's perpendicular to this structure, and we don't see any color. But it's actually false negative, because it's a low velocity and also very unfavorable angle of incidence. Here the incidence is close to 90 degrees, and we mentioned that for Doppler, echo, ultrasound beam should be aligned with the flow in blood. And at the same time, if we use power Doppler, we definitely see positive for blood flow. So we can say, okay, this is not a nerve, this is blood vessel. So now let's switch to next important terminology is echogenicity. So we'll be using different words to describe structures on a screen, and we'll be talking about hyperechoic structures. So this is the one that more echogenic, means brighter than surrounding tissue. When the object that we're looking is less echogenic than surrounding tissue, we would call it hypoechoic. When it's somewhat the same, we will call it isoechoic. And when there's no echoes at all, we'll call it anechoic. So when ultrasound passes through the tissue, there's always attenuation of energy of ultrasound sound beam. It progressively weakens, and this occurs in several different forms. So some of the sounds, of course, reflect back, and it's this process called reflection. Some of the sounds scatters and reflected in multiple directions, and a lot of echoes do not get actually back to transducer. Some of the sound wave will be redirected. It's called refraction, and some will be absorbed and converted to heat. So those are different forms of attenuation of sound in tissue. Next phenomena we're going to discuss is acoustic impedance. Acoustic impedance quantifies tendency of a material to resist transmission of sound wave. Essentially is how hard do I have to push on this to make it vibrate and transmit sound. And it's a very important notion in sonography, because tissue that have a different impedance and position close to each other are responsible for all these multiple echoes. So mismatch impedance interfaces create reflection point for sound. So here we have a table and we can see impedance of different tissues. Its impedance, for impedance we use letter Z. So for example, water, well, same as local anesthetic, impedances will be 148, while muscles and nerves close to each other, 1.68 for muscle and 1.70 for nerve. So this explains, for example, why we might have trouble sometimes seeing nerve, really discerning nerve, when we have muscle as a background for nerve. And this nerve immediately pops out, get more contrasted if we inject local anesthetic around it, because between water or local anesthetic around the nerve and nerve, we have a pretty big mismatch in impedance. And this mismatch impedance interface create nice reflection points for sound. It's also probably explained as this difference in impedance why it is easier to see the needle while you practice on a simulator on Blue Phantom compared to a real patient. Again, because mismatch in impedance between Blue Phantom and the needle is much higher than mismatch in impedance between needle and live tissues. So after you master Blue Phantom, start practicing on meat, and then you will be comfortable on patients. So next we're going to talk about positioning structure of interest on ultrasound screen. So machine is pretty smart, but we have to help machine to help us. So the engineers, they try to optimize image maximally in the center of the screen. So if there is some point of interest, you have to adjust your depths and adjust your proposition. So this point of interest is in the middle of the screen. So next we're going to discuss different transducers, and we'll talk about different frequencies. So some transducer produce high frequency signal and some produce low frequency signal. High, we talk about something like 10 to 15 megahertz and maybe higher than that. And low, it's 1 to 5 megahertz. So you have to remember that the higher the frequency, the better is resolution of the image. Resolution meaning ability to distinguish two separate points as separate, not smudged together. But at the same time, the higher the frequency, the less is penetration. And everything is vice versa with a low frequency transducer. It's less resolution, but it's higher penetration. And so when we're trying to choose the transducer for the task, the goal is to use the highest frequency possible that will reach the area of interest, providing the highest resolution. Also, you will notice that on our transducer, we see not just one number, let's say 5 or 10. We see a range here, for example, from 15 to 6 megahertz, and so called broadband transducer. And so again, we have to help machine to produce best picture for us. So we have to select where is the structure of interest. And we will do this by pushing special button. We have 3 modes. Resolution mode, this is designed for superficial structures. General mode, somewhere in the middle, and if object of interest in some way deep, we use penetration mode. And this is example how we have image, and we just change by toggling from resolution to general to penetration, and quality of image is changing. So let's talk about transducer design. So there's several designs. Most commonly we're going to use linear array probe. So this one is very common probe, pretty much our working horse. It has a frequency from 15 to 6 megahertz and has a 50 millimeters footprint, and it's a linear footprint, and so give us pretty decent panoramic view up to 50 millimeters wide if we go kind of deep. And the near field and far field are equal. There's another type of transducer, convex array or curvilinear transducers. They produce an image looking like a pizza slice. This one is another very common curved convex transducer. It's 5 to 2 megahertz. It's actually 5 to 2, and it's 60 millimeter footprint, and we see that it has this nice big panoramic view, especially in the far field, almost double in size compared to near field, and this is very useful for many purposes. We can have linear transducers or curvilinear transducer that will be different in the size of a footprint. So this one, small footprint transducer, about 2 centimeters footprint, and this is our standard, it's at 5 centimeters. And why we need those? The small footprint transducer, very handy when we need to negotiate those, small natural anatomical convexities and concavity. The problem is then that your scanning windows is also will be kind of a narrow. So you have to, instead of this panoramic view, you have to make up by moving your transducer a lot. So this is kind of an example of image from curved transducer. It's a nice big panoramic image. This is our standard linear transducer, and this is our small footprint linear transducer. So, and there's application for all three types. Another type of transducer is a phased array, also known as a cardiac transducer. This one is designed to, get us good image despite small acoustic windows between ribs. And we'll talk more about it when we talk about POCUS and echocardiography. It's very important to be cognizant about orientations. So transducer has an indicator right here, and screen has an orientation mark. And we have to always kind of make sure that we align them correctly and they're consistent. So, and there's some convention. So if we looking at, for example, something in a long axis or longitudinally, the convention is that the orientation marker that on regular ultrasound screen is usually in the upper left corner, and the orientation marker on a transducer is pointed towards the head of the patient. While if transducer is oriented transversely, then orientation marker is toward on the transducer toward patient right, or I usually use it toward my left because I'm facing the screen. So let's talk about scanning planes again, so we can use same language. So this is a longitudinal scanning plane. Now this is logically will be transverse scanning plane, and this one is coronal scanning planes. So when engineers design ultrasound machine, they did all the small adjustment that will produce the best image for a particular type of exam. So it's very important for you to choose appropriate exam. And there's a multiple options here, so choose correct exam type. So if you examine abdomen, use abdominal. If it's cardiac, use cardiac. If it's, lung, it's lung, and so on, so on. So now let's talk more about knobology. There's a three initial systems of control. The first one is depth. So if we put probe in the patient and depth is not enough, too shallow, we can increase the depth. At the same time, if we put probe in a patient and we have too much of a depth, we can decrease it, and by decreasing depth we also will kind of magnify the image. So I will demonstrate this. So here we have too much of depth, about 5.5 centimeters, right? And as we decrease depth, you see that our interest point, our structure of interest, this vessel, getting bigger and bigger as we go from 5 to 4 and finally to 3 centimeters. And as we said, we usually adjust the depth so the our point of interest somewhere in the middle of the screen that will result in the best picture. So another system of control is time gain compensation, TGC. Sometimes we'll see TGC button. Sometimes we have two buttons, one near, one far. And the whole idea is to adjust returning echoes, its intensity, to have the same image intensity regardless of the depth. So I'll demonstrate it so it's clear. So this is TGC, split it in two knobs, one control near, one control far, and this one gain in general. So in this how we have a field near field and far field. They kind of balanced here. In this example, when we have far field that is under gain, here is opposite, the near field is under gain, and here is balanced picture. So you can actually adjust it, and the goal is to have equal intensity throughout the image despite the depth. And the last knob, last point of control will be gain overall. And again, to increase or decrease intensity of all returning echoes equally, regardless of the depth. And so this kind of like Goldilocks example again. This is not enough. This is too much. And here's just right amount of gain. So if I summarize, to optimize the image, we have to first choose proper transducer, meaning proper frequency, proper type, curve versus linear, and proper footprint. Because we frequently will be dealing with broadband transducer, we can adjust the frequency by choosing resolution, gain, and penetration. We should choose appropriate exam. It could be nerve, MSK, arterial, venous, abdominal, lung, and others. We have to always remember and position transducer with the correct orientation to screen. We should adjust the depth, so target is in the middle of screen, and adjust both gain and time gain compensation. So now let's move to the probe movement terminology. So this is universal terminology, and we will be using it consistently so we can understand each other and help each other. When I'm teaching, I will be saying do this or this. So first movement is fanning, and this is actually self-explanatory. Just look at a picture and see what is fan. It's just basically a changing angle. Some people erroneously call it tilting. So fanning is a better term. Another one is sliding. That's how we move transducer, by sliding in the long axis across the body. If we move in across the short axis, this will be sweep, like we're sweeping with a, when we sweep in the floor. This movement called rocking. During rocking, we apply more pressure on, for example, nose of the transducer, or vice versa, more on the heel of transducer. If we equally apply pressure on both poles, that will be pressure or compression. And if we rotate according to the z-axis, this will be rotation. So again, we have those axes, x along the short axis of the probe, y along the long axis of the probe, z along the kind of a cable, and we can do fanning, sliding, sweeping, rocking, pressure, and rotation. 6 fundamental probe movement that we'll be doing to optimize our image. So let's talk about cross sections. So we will be looking at 3-dimensional structures, but on a screen we'll see 2-dimensional image. And there's a two kind of a view, short axis view. So this is, we're looking at a cylinder, and this is short axis view. It will look like a sphere, like a circle. I'm sorry, like a circle. And this is long axis of the cylinder. And so it's kind of very simple, but imagine that nerves and blood vessels and needle and basically any organs could be viewed both in long and short axis. So we frequently will be using those terms. We're gonna look at the nerve in short axis or in a long axis. We're gonna look at the needle in a long axis and a short axis and so on. So another important point here is angle of incidence. So we look at this image, we have the skin, right? And this is our tissue interface, let's say fascial plane, or this could be nerve, right? And we're gonna pay attention to those ultrasound signals. So the best echo coming back will happen when angle of incidence between ultrasound beam and a tissue is close to 90 degrees. If angle of incidence is different, you'll see that a lot of echo actually will go away from the probe, and it will definitely weaken the returning signal and will affect our image. So one time, ultrasound waves reflect back to the probe most directly when the probe and tissue plane or needle are at 90 degrees angle of incidence. And to optimize this angle of incidence, we'll be frequently use fanning or rocking of the probe. And you have to remember that it's not uncommon that there is this, the skin surface and, anatomical structure surface like a fascial plane and nerve will be not parallel to each other. So it's very useful concept to understand. And here I'm showing an example how using angle of incidence concept to improve needle visualization. So imagine here, for example, angle of incidence between ultrasound beam and the needle is quite unfavorable because a lot of echoes will be coming away from a transducer. While here is perfect, it's 90 degrees, right? So sometimes in this particular case, in order to improve needle visualization, right, we can do following tricks. First, we can slide our probe back a little bit, so now our target is not in the middle of the screen, but rather on the edge of the screen. Then instead of entering skin close to the probe, we can start a little bit further away. And as a result, we see that angle between ultrasound probe and the needle getting closer and closer to 90 degrees. Another way of improving angle of incidence will be rocking the probe, right? If we're thinking about in-plane needling, or fanning the probe appropriately when we're talking about out-of-plane needling. Next, very important phenomena is anisotropy, and it's different than just angle of incidence. It refers to tissue quality, right? Some tissue, for example, nerves and tendons, exhibit this physical property of anisotropy, and it's defined as a different echogenicity based on small changes in angle of incidence. So this is an example. So here, look, this is angulation between ultrasound probe and structure. In this case, we're talking about nerve. Here's this nerve. And if you look, it's the same picture, right? We do small changes. Here's 81 degree, here's 84 degree, here's 87 degree, and here's 90 degree. So really not a big deal. From 81 to 90, we have a huge difference in echogenicity of our nerve. We go from highly hyperechoic, nice and bright, to almost invisible. So it's almost now you see me, now you don't phenomena. And it's very common for nerves, and that's why later on we'll be talking about this um, stage-wise approach when we're trying to locate nerves. We just have to know where nerve's supposed to be, and then we start doing these small changes in angle of incidence, small fanning, and it will bring about a good picture of the nerve, right? And we'll see it a lot when we start practicing. So let's really quickly talk about ultrasound artifact. So artifact means that we see something on the screen that is not true or vice versa. It's quite complicated topics, right? Most artifacts are related to physics of ultrasound, mostly to phenomena of attenuation. And this is somewhat advanced topic and is more important for diagnostic and not procedural ultrasound, but we'll just go through most common artifacts. So the first one, acoustic enhancement. So below large vessels of fluid collection, we'll see this enhancement, right? We see this nice hyperechoic something, right? And it could mimic nerve. And in reality, it's just a regular tissue, but because ultrasound beam was going completely without attenuation through the fluid, we see here enhancement compared to ultrasound beam that was going through tissue, was attenuating, let's say, normally. And that's important because a lot of nerve blocks are done around vessels, let's say infraclavicular, one of the good examples, or axillary, and people would be thinking that right here is a nerve, but in reality it's just an enhancement artifact. Another one, important reverberation artifact, we'll be talking about this when we discussing lung ultrasound, A lines so-called, but commonly we'll see during procedures when you do in-plane needling, and you're going to see these ghost images of a needle, and this kind of a picture explain how it happens. You see how ultrasound, sometimes get trapped inside the needle, and as a result, computer plot later on not just one real needle, but several echoes of non-existent needle. Another one common is a mirror image artifact. So rib, sometimes pleura, create this mirror surface and a mirror effect, and you will see above rib, for example, here, nice structure will be your artery, and you will see a mirror artifact of artery below the rib, even though there is no artery. And it's actually seen in both 2D and color Doppler as well. Acoustic shadow artifact. Here we're showing the needle, and needle casts this acoustic shadow, and it's like drop out. There's no picture here. This is very common with, let's say, bony structures. Imagine ribs creating those acoustic shadows on the liver, or when you do paravertebral or intercostals. So that's also a very common artifact that you have to know. So let's go to the final stage of the lecture, identifying tissues, different tissues and structures on ultrasound image. So first I want to tell you that it's actually very intuitive, and the moment you start scanning, it really doesn't require much to get used to it. But let's just go and describe. So bone, like this, right? Bone is here, it's humerus, appears anechoic almost, with a bright hyperechoic rim. And bone usually casts nice and dense acoustic shadow, so you don't see anything below bone. As we'll show some more examples. Muscle look hypoechoic. This is a nice muscle right here, and they have this striation. Back. Fat have this loose areola kind of a tissue, and frequently hypoechoic. He is not really hypoechoic, but frequently it's a nice and dark fat. And fascia usually nice and bright and hyperechoic because it creates those, mismatched impedance interfaces. So how about vessels? Vessels appear black or anechoic in 2D. So veins are usually compressible. So right here we have uttering veins. So if you apply some pressure on ultrasound, vein will be compressible. Arteries pulsatile, but sometimes pulsatility kind of get transmitted to the vein. We can use color Dopplers and confirm that those are vessels, not nerves. We discussed this. And again, remember that blue and red, it's not that blue is vein and red is artery, right? Blue away, red towards. So it depends on angulation of a transducer towards the vessel. Because I can, see blue and red, but then I, change angulation and it will be opposite. Again, frequently below vessels we have this acoustic enhancement, right? And in the small vessels, to distinguish them with nerves, we have to use power Doppler. So what about nerves? Appearance of nerve depends on location, proximity to spinal cord. So if we're talking about proximal nerve, they look hypoechoic. So this is C5 and C6, and this is C7 nerve roots. So they look completely anechoic, right? Black pearls. As nerves goes further away from a nerve axis, we see more and more so-called honeycombing appearance, right? Some people call it chocolate cookies with, stippled structure. The hypoechoic, you see those black dots would be representing fascicles, right? And the hyperechoic will be the, endoneurium, nerve stroma. So another example here, we have a vessel here, right? This is ulnar artery, right? And right here we have ulnar nerve, hyperechoic ulnar nerve. Tendon. So tendons look very much sometimes similar to nerve. So this is image for like a tibial nerve block at the ankle. We have the Achilles tendon, we have a medial malleoli. So this is our tibial nerve. We have vessels here, artery and two veins. But I want to, bring your attention to tendons, right? So the tendon here, tibialis posterior, right, looks almost like a nerve here, tibial nerve. And sometimes, tendons here looks like nerve too, right? Tendon of flexor hallucis longus. And so sometimes in order to distinguish those, right, besides knowing anatomy and position, Tom, Dick, and Harry, right, you just have to track those structures. And that brings us to so-called dynamic imaging. Frequently when we're in doubt, we just slide ultrasound along the structure from, point we started to a little bit more proximally or more distally. And of course, if this is a nerve, it will stay nerve. But if this is a tendon of a muscle, it will turn into the nice juicy muscle belly, and it will be then clear which is which. So, and this is the end of our introductory lecture. Thank you very much.